Hey everyone, I'm Dr. Akansha. Welcome to this introductory explainer focusing on the oral manifestations of hypothyroidism. It's pretty wild to think about, right? A systemic endocrine disorder acting like a silent saboteur right inside the mouth. It's a truly fascinating topic that bridges the gap between systemic medicine and what we see every single day in dental practice.
Let me ask you a question. Could you, as a dentist, be the very first person to actually diagnose a silent thyroid disorder? Well, absolutely. You're in a prime position to spot the subtle, localized clues of a much broader systemic issue. Think about it. Patients sit in your chair completely unaware that their exhaustion or their stubborn gum disease is actually stemming from their thyroid gland.
Okay, let's take a quick look at our roadmap for today. We are going to cover 1. The thyroid-oral connection, 2. General clinical symptoms, 3. Uncovering oral manifestations, 4. The periodontal disease link, and finally, altering our dental treatments. All right, Section 1. The thyroid-oral connection, focusing on the body's master metabolic regulator. Let's do a super quick review of the thyroid gland itself. Sitting right anterolateral to the trachea, it basically acts as the literal engine room of the human body. It pumps out two main hormones, T3 and T4, and these two are completely responsible for regulating growth, development, and your basic metabolic functions. Now, hypothyroidism happens when there's a fundamental breakdown in this engine, basically inadequate hormone synthesis. For most adult patients, the biggest culprit is an autoimmune condition like Hashimoto's thyroiditis, although globally, iodine deficiency is still a massive factor. Moving right along to Section 2, General Clinical Symptoms. Let's look at what happens when the system slows down. Before we even peek inside the oral cavity, we really have to understand how this hormone drop affects the whole patient. Because the metabolic rate just plummets, every single system in the body hits the brakes. This leads to classic, highly visible clinical signs. Your patient might complain of extreme fatigue and somnolence. We're talking sleeping 12 to 14 hours a day and still waking up exhausted. You'll likely see unexplained weight gain, severe cold intolerance, and a noticeably slowed heart rate known as bradycardia. There is often a mental sluggishness too. And in severe, long-standing cases, patients can develop myxedema, which gives their skin and tissues a really distinct, puffy, edematous appearance. All right, Section 3, Uncovering Oral Manifestations. This is where we truly view the mouth as a mirror to the body. Now, this is where it gets really interesting for us. How does this systemic crash actually present locally in the stomatognathix system? Think about the contrast here. While a hyperactive thyroid might cause accelerated tooth eruption, hypothyroid goes the other way. It triggers anomalies like enamel hypoplasia, an anterior open bite, unusually thick lips, and even mouth breathing. It's a really stark contrast that perfectly demonstrates how a lack of metabolic drive directly alters the whole oral architecture. You might be wondering about macroglossia, or an abnormally enlarged tongue. Let's break down the why behind that. The tongue isn't just spontaneously growing new muscle. What's happening is it's accumulating specific compounds called glycosaminoglycans. In a healthy system, these subcutaneous mucopolysaccharides would just get broken down naturally. But because of that sluggish metabolism we talked about, they don't. They fail to break down and just accumulate in the tissues, causing the tongue and lips to become abnormally thick. This hormone drop also triggers two super uncomfortable sensory issues for our patients. First up is dysgeusia, which is this incredibly frustrating loss or alteration of taste and smell. And this happens because of a synaptic delay of impulses and underdeveloped taste buds. On the flip side, they might deal with burning mouth syndrome. They'll describe a burning sensation right on their cheeks, the tip of their tongue, or the edges. Why is that? Well, underdeveloped papillae leave the mucosa completely raw and hypersensitive to even the most minor stimuli. So when your patients complain about these things, it's not just in their heads, it's deeply rooted in altered neural and mucosal development. And wow, do these complications get even more pronounced in our pediatric patients? In kids, severe hypothyroidism, historically called cretinism, causes massive delays in tooth eruption and cranial development. When you have an 8 or 9-year-old sitting in your chair with severely delayed tooth eruption chronology, you have to put on your detective hat. You might actually be the very first person to realize their thyroid is failing to stimulate normal bone and dental maturation. This brings us to Section 4, the periodontal disease link. Let's look at this fascinating bidirectional relationship. We really need to understand how thyroid dysfunction actively sabotages the periodontium through a crazy bidirectional trap. Systemically, a lack of thyroid hormone decreases bone turnover and increases capillary permeability. That literally causes swollen edematous gums. But here's the kicker.
Locally, once that periodontal inflammation sets in, it starts releasing pro-inflammatory cytokines like IL-6 and TNF straight into the bloodstream. This local gum infection then goes and exacerbates the systemic endocrine stress. It's this vicious cycle where the thyroid weakens the gums, and then the infected gums turn around and stress out the body's immune system even more. So the root of all this is a severe biomechanical breakdown. Because osteoblast and osteoclast activity drops, bone remodeling essentially just stalls out. Plus, increased serotonin metabolism messes with the constrictor tone of the blood vessels. Add in a drop in fibroblast activity, which severely delays wound healing, and you've got a perfect storm. Clinically, what does this actually look like for you? It results in significantly deeper probing pockets. We're talking a high prevalence of pockets deeper than 4 to 5 millimeters. You're definitely going to see higher rates of clinical attachment loss and bleeding on probing. This is exactly why your hypothyroid patients often walk in with generalized severe periodontitis.
All right, Section 5, altering dental treatments, focusing on clinical protocols for patient safety.
Because of everything we just went over, we absolutely cannot treat these patients with our standard, everyday dental protocols. The medical literature is super clear on this. An uncontrolled hypothyroid patient is a high-risk patient in the dental chair, period. Their bodies just cannot handle the normal stresses of dental surgery or even certain routine medications, the way a healthy patient's body can.
Let's break this down into 3 crucial, actionable steps you need to memorize to prevent a medical emergency. Step 1. Always assess their cardiovascular status and request a complete blood count before doing any invasive procedures. Remember, their heart rate is already compromised. Step 2. Avoid central nervous system depressants entirely. Their system is already artificially depressed, so using CNS depressants is a huge red flag. Also, use adrenaline with extreme caution. And step 3. Defer all elective surgical procedures if their disease is undiagnosed or poorly controlled. Honestly, it is just not worth the risk.
Now, why are we being so incredibly strict about this? Well, it's because of the absolute worst-case scenario, a myxodematous coma. This is a severe, life-threatening complication. And what actually triggers it right there in the dental chair? Exactly what we just talked about: surgical stress, untreated oral infections, or giving them CNS depressants. If your patient suddenly starts showing signs of hypothermia, severe hypotension, extreme bradycardia, or even epileptic seizures, you need to act immediately. Discontinue treatment right that second and alert emergency medical services. This right here is why knowing your patient's thyroid control isn't just a box to check, it's literally a matter of life and death.
So, I want to leave you with this one thought. If the mouth truly is the mirror to the body, what systemic secrets is your next patient's smile trying to tell you? When we recognize that good dentistry is actually essential systemic medicine, it empowers us to provide much safer, comprehensive care. Thank you so much for joining me for this explainer. Keep looking closely for those hidden clues and keep learning.